I'm Marilyn Gallucci. I'm a professor here and director of geriatrics education and research. And you are here for the Humanism and Aging Leadership lecture and award ceremony. So thank you so much for coming. In our audience today, we have the UNECOM, University of New England College of Osteopathic Medicine, UNECOM students, we have UNECOM fellows, we have possibly neuromuscular medicine residents here. We have pre-health majors from our College of Arts and Sciences. We have faculty, staff, and we have community invitees, community guests, and we also have our GEMS mentors. So our GEMS mentors are the people that new this year, Geriatrics Education Mentorship with Seniors. 2 second-year students are paired up with every adult, and they meet 4 times throughout the year and have different projects to do. Would our GEMS mentors mind standing up? We have about 20 here out of the 60 that we are working with. These are our GEMS mentors. And the great part is our students love them, and you seem to enjoy our students, right? They're having a great time. Thank you so much for being here, making that effort. This is also being video streamed to the Portland campus. It is being recorded for your future listening, viewing pleasure for anybody who hasn't made this. One of my other roles is to be the advisor for the American Geriatric Society / UNECOM student chapter, what we lovingly call the Geriatrics Club. This award was originally funded by the Arnold P. Gold Foundation. And one of the reasons why we were successful in getting this grant to start this award was because we had an action component into it. So we said we would bring in a prominent geriatrician with a humanistic approach to aging. That person would come in and do a lecture for us, meet with our leaders, meet with our community members, and the students and fellows, the UNECOM students and fellows and residents that were in the audience, they have an opportunity, and we're handing out this sheet if you haven't gotten it, to do something academic, most write an essay, the criteria are on this form, to respond to the question, how will you apply what you've learned from Dr. Rowe's lecture today in your future practice as a physician? Then we have a team that reviews those, and the final, usually 5, 6, we get to Dr. Rowe, and he will make the final determination of first, second, third place and honorable mention. And those are the winners of what we call the Humanism and Aging Action Award. And then in the spring, those students will present their essays, and there'll be an awards lunch, and they will get a plaque and find money. Nice, they get some money. And it certainly looks nice on their CV. So that's a nice, well-rounded way to do it. And without further ado, what I would like to do is introduce our co-presidents for the American Geriatric Society UNECOM Student Chapter. We have Holly Laird and Catherine Kelly, and they will do the awards presentation, and then Dr. Rowe will give his lecture. You are on. Thank you.
Thank you. Thank you again, everyone, for joining us this afternoon. I'm Catherine Kelly. This is Holly Laird, and I have the pleasure of telling you a little bit more about our very esteemed guest today. Dr. Rowe is professor in the Department of Health Policy and Management at the Columbia University Mailman School of Public Health. From 2000 until his retirement in late 2006, Dr. Rowe served as chairman and CEO of Aetna Incorporated. From 1998 to 2000, he served as president and chief executive officer of Mount Sinai NYU Health, one of the nation's largest academic healthcare organizations. From 1988 to 1998, prior to the Mount Sinai NYU Health merger, Dr. Rowe was president of the Mount Sinai Hospital and the Mount Sinai School of Medicine in New York City. Before joining Mount Sinai, Dr. Rowe was a professor of medicine and the founding director of the Division on Aging at the Harvard Medical School, as well as chief of gerontology at Boston's Beth Israel Hospital. He has authored over 200 scientific publications, mostly on the physiology of the aging process, including a leading textbook of geriatric medicine, in addition to his well-known book, Successful Aging. co-authored with Robert Kahn, PhD. His recent publications are on healthcare policy. Dr. Rowe has received many honors and awards for his research and health policy efforts regarding the care of older adults. He has served as president of the Gerontological Society of America. Additionally, he was director of the MacArthur Foundation Research Network on Successful Aging. He's a former member of the Medicare Payment Advisory Commission and currently leads the MacArthur Foundation's Research Network on an Aging Society. He chaired the committee of the Institute of Medicine on the future healthcare workforce needs of an aging population. Dr. Rowe was elected a member of the Institute of Medicine of the National Academy of Sciences, where he is involved in the evidence-based roundtable and is a fellow of the American Academy of Arts and Sciences. In addition, Dr. Rowe is chairman of the Board of Trustees at the Marine Biological Laboratory in Woods Hole, Massachusetts, and he's on the Board of Trustees of the Arnold P. Gold Foundation. Dr. Rowe, we're very honored to present you this award today.
Thank you very much. What we want to do is put this between us.
Okay. Thank you.
And the award, if you don't mind.
Yes.
And then Catherine.
Absolutely.
Yeah, it's good in there, close.
Let me do that.
Great, thank you.
So for our audience, I'll read the award. This is from University of New England's College of Osteopathic Medicine, the Department of Geriatric Medicine. It is the Humanism in Aging Leadership Award, and it's presented to John W. Rowe, MD, of Columbia University, in appreciation of his transformational leadership and humanistic approach to the care of the whole person to promote successful aging for older adults and their caregivers, 2013 to 14.
Thank you. Thank you so much. Great, thanks. Terrific.
That's good.
Okay. Well, thank you very much. Thank you all for coming. I'm having a delightful visit here. This is my first visit, and I'm learning a lot about your school. And I've had a chance to talk with a number of your school leaders, as well as to have a time last night at dinner with a number of the students who are interested in geriatrics, which is always a great pleasure. What I'm going to do is talk with you not so much about geriatric medicine per se, but at the kind of next level up, and that is about some broader societal considerations. Some years ago, a number of my colleagues and I had the great good fortune to be supported by the MacArthur Foundation to do some research on aging over the course of a decade, and we tried to understand what the factors were that permitted individuals to age successfully. Our rationale was that those factors were not the reciprocal of the factors that led people to age unsuccessfully. So that if smoking is bad for you, not smoking doesn't guarantee that you're going to age well. And we thought there were other factors. And we studied that for a long time. We published 100 papers or so. We wrote a book that was well received. But the foundation and we also realized that if in fact we got to the point where people were aging successfully in large numbers, and we are having an epidemic of successful aging, as you probably have noticed if you look around, that at that point the unit of analysis has to change from the individual to society. And that is, how is our society prepared and how must it change in order to react and adapt to this demographic transformation. Now, previously unimagined numbers of people are living to be very, very old in the United States. And so, again, with characteristically very generous support from the MacArthur Foundation, we've assembled a group of 12 scholars from around the country and from Europe who have been working with me on this project for several years. as we began these considerations, and we began to have a policy focus so that we're not so much trying to publish papers as we are to influence senators and congressmen and governors and civic leaders, we found that the view of an aging society was encapsulated in a series of concentric leather-like myths, that people had these beliefs about an aging society, and we couldn't get anywhere with trying to establish policies that would be effective if we didn't break down these myths. So our fundamental question is this: the core institutions of our society, and by that I mean work, retirement, education, the structure of the family, the design of our environments, our transportation system, whatever. The core institutions of our society were not designed to support a population with the age distribution of our future population. That's the problem. The question is, how are we going to re-engineer the core institutions of our society in order to support our future population? And here are some of the myths that we ran into. And there's just 7 or 8 of them. This won't take that long. You'll have time for dessert. America's aging society will be a transient demographic phenomenon caused by the baby boom. Dr. Rowe, you know, it's interesting you're doing this, but we don't really need to hear this because this is going to pass. In Washington, they view the baby boom, it's sort of like a swallowed mouse moving through a snake. You know, and when it goes out the other end, the snake is going to be back to the way it was in the beginning. But the fact is that the demographic transformation that we're seeing in this country is a function of not only the baby boom, of which I'm a proud member, but also a very dramatic increase in life expectancy and, in fact, active life expectancy. So here, this is a little complex. It's one of my favorite slides, though. It's a little complex, and it's got all kinds of colors and things here. But, so if you just look at the center of this slide, and you look at the purple area here, this is 1900. This is our population. This is a standard way of showing it. These are age bands, 0 to 4, 5 to 9, and so on. Okay? And by convention, the women are on the right, and the men are on the wrong. And, it's always the way it is. And what you see is in 1900, what we had was a very pyramidal age distribution, which was known as the age pyramid. And it made perfect sense. And then what you see in 1950 is you see that there's a kind of bulge here, and then there's this little group sticking out here, and those are the baby boomers. Those are the first group of baby boomers that were born between 1946 and 1950. And then in 2000, those baby boomers were up here, okay, middle age. 2050, they'll be just almost all gone, okay, more women than men, of course. But what you see, once this group leaves, what you see is a dramatically different distribution than what we had. So we've got more of a rectangular distribution of our population rather than the pyramidal distribution that we have. Myth number 2 is to be old is to have diminished capacity. And that used to be true, you know, that the older you are, the sicker you are, and that's still true in a population-based way. But the fact is that many, many, many people are old and are not diminished intellectually or physically. And it turns out that if you're trying to understand what the likelihood is that someone is going to be sick or disabled, and you have one question to ask them, the best question is not how old are you, the best question is how much education do you have? So if you look at the percent of people in fair or poor health, so health is measured in this scale in 4 ways: excellent, good, fair, poor. So fair, poor is the lower half of the group. By age, this is the National Health Interview Survey, between 1982 and the year 2000, there was a dramatic improvement in the function of individuals at advanced age. If we take age 65, a common measure, in 1982, you had a 30% chance of being in poor health. At age 65 in 2002, that was down to a 20% chance. This is a huge difference, this area between the curve. But if you look at what has happened since then, these are 5 different surveys. This is the Medicare Current Beneficiary Survey, the Ann Haynes Survey, the Health and Retirement Survey, and so on. This is functional capacity, percent of individuals who have a limitation since 2000 to 2008, and what you see is, in all these surveys, flat. So the reduction in the disability that went on progressively for 20 years from 1980s to 2000 has stopped. And the old people that we're going to see in the future are the ones that we have now. That's the functional capacity that we're going to see. We cannot expect this progressive, continued improvement. We have reached what appears to be the limit. Number 3, the key age group in an aging society is the elderly. Now, I know that this seems intuitive. And actually, after we wrote a first paper that we published about these myths, I sent it a copy to the president of the MacArthur Foundation, who's my sponsor, and he wrote me back and he said, "Jack, I'm really glad you sent me this." He said, "I thought they were all true, every one of them." He said, "This is very," and he said, "but particularly number 3. Well, let me tell you why this is a myth. Because we're trying to force the issue that society is the unit of analysis, not an individual age group. So as you are all probably aware, Europe has been aging ahead of us. After World War II, we had a baby boom, they had a baby bust. They had fewer births, and therefore the number of individuals who were old in the population was a greater proportion of the population. The average age of the population was greater than ours. Germany now looks like the United States will look in 2030. Has the same exact age distribution we're going to have in about 15 or 20 years. So what happened in Europe with all the increased demand for funding of the entitlements for the elderly? Did they cut the Social Security-like programs? Did they cut the health care programs? No. What did they cut? What did they cut in Europe to fund that? They cut the educational budgets. So what population of individuals was most influenced by the aging of Europe? Youth. It's the youth who are at risk. They don't have the political power. Very interesting. Intergenerational political warfare is inevitable. Now, you read this a lot. Everybody thinks this is true. The greedy geezers. I have a friend, Pete Peterson, who was Secretary of Commerce once, has written on this. He's written a book. Actually, he's written about 4 books, but it's the same book on this, about the coming intergenerational warfare. And this makes perfect sense. The only problem with this is that there's no evidence in favor of it. And there's a fair amount of evidence against it. It turns out that survey after survey shows that middle-aged people and young people support Social Security. In fact, in one of the recent surveys, and these surveys are done all the time, middle-aged people had a higher proportion of supporting Social Security than the elderly. Why are they so bullish about Social Security? Well, they're bullish about it for 2 reasons. Number 1 is they have been paying into it. They see it as their safety net, and they're not too excited about having it go away. But number two, which I think for many of them is more important, is that they recognize that the Social Security system was established as a financial benefit for middle-aged people. That was the goal of the Social Security system. And if Social Security didn't exist, they would be paying for their parents' rent. They would be paying for their parents' food. Their parents might be living with them. It is a financial benefit for middle-aged people, and they realize it. Policymakers must choose between investments in youth or the elderly. It's another obvious one. Are we going to fund the children, or are we going to fund the elderly? Well, what we believe is that if you look at society and not individual age groups, that in fact you can have win-win scenarios, you can have intergenerational benefits that are very important. As you all probably are aware, the generational flow of funds is generally from the top down. So older people don't live off their children. They give to their children and their grandchildren. In the United States, older people are net givers to younger generations until age 83 or 84, at which point they start to use more resources. So let me give you an example of an intergenerational win-win. This is my favorite example in the world, and it's fitting that we discuss it this week given the fact that Nelson Mandela recently passed away. In South Africa, when Mandela became president, and afterwards, they decided to establish a social security system for poor elderly people, almost all of whom were black, and most of whom had worked in agriculture their entire life. And they had no equity. They had just not developed any funds, any ownership. And then they studied these households over town. In many of these households, there were no men who were adults, it was just women. There were many grandchildren in these households. And an outstanding economist named Esther Duflo from MIT published a paper analyzing the program. And what she found was that in the households in which the elderly black women were given the Social Security payments, the grandchildren were taller and did better in school. They were taller because they had more food to eat, and they did better in school because they didn't have to work in the field. That is an intergenerational benefit. Why can't we be smart enough to design some of these? The principal problems of an aging society relate to Social Security and Medicare, Medicaid. Everybody knows that's right. If we fix the Medicare, Medicaid trust fund, and that won't be easy, and the Social Security trust fund, which we could fix in the next 10 minutes, that's really easy, and everybody knows how to do it. They just don't have the guts to do it. But that's an easy one. If we fix those things, and we don't re-engineer the core institutions of our society, we will fail. Because the success of our developing a productive and an equitable society in the future is not dependent on the Medicare and Social Security Trust Fund. It is, in fact, dependent on our having a cohesive, productive, effective society. The problem of an aging society can be fixed through increased immigration. No, Senator. I'm sorry, Senator. That's not going to work. if you wanted to increase immigration to the point where you kept the proportion of old people to the proportion of young people constant, you could do it. But you would have to increase immigration by 1,000%. It's not going to happen. In addition, there's another very significant problem. It has recently been discovered that immigrants age. So, in fact, you would have to do it every year. Old workers must leave the workforce to make room for younger workers. I read this in the New York Times last week. A guy named Callahan, Dan Callahan, who's an ethicist, wrote an article about it. I can't believe these guys. This is intuitive and it is incorrect. So if you look at economics textbooks from 10 years ago or 15 years ago, you'll see this in it, and they describe it as the lump of labor. The idea is there is a lump of labor, and if these old people are doing some of it, then there's less for young people to do of it. It's intuitive. And it's described in those textbooks as the lump of labor hypothesis. And there's been a lot of research in the United States and in Europe. In the United States, David Wise and Jonathan Gruber are amongst the leaders here. In Europe, a fellow named Axel Borsch-Suppan, who runs the Max Planck Institute in Munich. And what they have both shown over and over and over again is that there is no relationship between old age employment and youth employment that is reciprocal. It is direct. If old age employment is high, youth employment is high. Those are strong economies. If old age employment is weak, youth employment is weak, those are weak economies. But there's no reciprocity. And in fact, if you pick up an economics textbook now, you will read about the lump of labor fallacy, not the lump of labor hypothesis, because it's been disproven. So what would failure look like? If we are not successful in making the kinds of societal changes that we need to make, and we have long lists of recommendations about what to do about education, what to do about retirement, what to do about work, and what to do about everything. No shortage of recommendations. This is what's going to happen. There will be wider gaps in opportunity, education, and wellness between the haves and the have-nots. We cannot afford that. That will tear apart the fabric of our society. We already have too wide and too rapidly growing gaps between the haves and the have-nots. We will have a lack of capacity to meet societal demand for goods and services. If we can't figure out a way to keep old people in the workforce and keep them productive, we're not going to be able to, in fact, be productive as a society. We will fail in addition to benefit from the potential contributions of what is now a very large, experienced, and largely healthy older population. We are just going to let them go, and we're not going to benefit at all from their experience and wisdom. And that, in fact, is something that we have to avoid. So, my sense, and I don't know if I can easily turn this off or not, so I'm not going to try here, but is that what we need to do is to try to begin some sort of a broad educational initiative to get everybody in our society to understand that these things are, in fact, not true. And if we can, in fact, begin to get individuals and perhaps our elected officials to understand that, then perhaps we can begin to think about what the individual policy decisions are that we can make progress in. I would have to also tell you, as somebody who spends a lot of time in Washington trying to sell my wares, that this is a very, very difficult time to get people to really pay attention to these issues. Give you an idea of how bad it is. I was talking to one congressman, very respected congressman, who was being very respectful of me, and I really thought I had him. I was talking to him, he was listening, but then he just didn't buy a couple of these things, and he said, you know, we've got these terrible problems with gridlock in Washington, and I'm not really sure we can make some progress here, and you know, we just closed down the government for 2 weeks, and blah, blah, blah. And I said to him, I said, John, you're my nephew. You're my sister's son. You have to hear me out. He said, okay, Uncle Jack, I'll take it. And then I left and I said, if I can't make it with my nephew, how am I going to do with Senator Cruz, you know? So anyway, but let me thank you again. It's a great pleasure to visit your fabulous medical school here in the university, and I appreciate the hospitality. Thanks very much. I'd be happy to hear whatever comments there might be or address whatever questions people might want to
There's
ask.
a burning issue for me, actually, I'll start it off. And that is, especially in geriatrics, gerontology programs across the country, that everybody addresses the issue with logic. And yet aging is an emotional issue. People are afraid of their own aging. It gets a bum rap in our society. And yet we keep going at it logically. So there's got to be some way to shift a little bit to have people emotionally kind of move off the dime in order to make these things happen.
Yeah. I think that's a risky strategy. And so my preference through my career has always been to try to be scientifically and evidence-based. And I'll tell you, it's not only because I lack charisma and they aren't able to present a persuasive argument for the dignity and et cetera piece of this. It's because in policy circles, you run into, if you do that, you run into the children versus the elderly argument. And they start rolling out these kids who lost their hair in the chemotherapy, and these kids who need this, and these poor kids doing that, and these homeless kids, and these kids in the street, and you know, it's you wind up in this argument, which is just gets hard, I think, and counterproductive. So I mean, I like the dignity piece. I think that. For instance, I think that was very helpful as we tried to change palliative care and care at the end of life. We're talking about having dignity. We're not talking about how much it costs or how much it saves. We're talking about having dignity. You can make that case. But when you start to get into the argument of one generation versus another because one has more needs, it's tough. It's tough. It might work at the state level. It's tough at the federal level.
I think people are afraid of aging.
They are afraid of aging. And, but you know, that's, if I'm going to try to convince people not to be afraid of it, I mean, I'm just, you know, I'm too old to start that. I mean, I'd rather try to get the, you know, age and eligibility for Social Security advanced 2 years. I mean, I think that would help, you know, some more practical economic solutions. Anything else? Yes. Dr. Reese and I last met in 1969 when we were on rounds together. The Q-Wing. And he was my supervisor. And I was a lonely student bumbling along, and there he was, a hot young intern. Hasn't changed a bit. Just look at him. Just look at it. Hasn't changed a bit.
Do you still remember your question?
The core institutions, if we're going to change those in America, Congress is going to have to be involved. And if somebody as influential as you can't exchange a congressperson with a relative connection, say, who might listen a little longer. What's the next? How do you approach the?
Yeah, no, I understand. I do feel some days like Sisyphus, you know, and just, you know, pushing the rock up the hill and it comes back down. On the other hand, there's a positive thing going on here too. I mean, first of all, look at what the MacArthur Foundation has given us all this money to do this. Well, that's a good sign. Somebody cares, right? You know? I mean, they asked, and in fact, they asked me. I didn't ask them. This is an unsolicited thing. They called me and said, could you work on this for us? Here's $7 million for 7 years. And I get a much better reception than I used to get. And I mean, I went to the gerontology meetings in New Orleans, and everyone was there recently. There were thousands and thousands of people. When I was president of the Gerontological Society, we could have had the annual meeting in this room. So, I mean, I think we're getting there. I don't mean to be too skeptical and cynical, but it is a very tough road to hoe in the current political environment, because it's kind of the last thing anybody wants to worry about, you know. Although they are happy to hear that immigration isn't the answer. Yeah.
Could you talk a little bit about what you think the effect of an increasing Alzheimer's population is going to do with your myths and realities of an aging society?
Yeah. So the question is about Alzheimer's disease, and obviously, as you know, the older you become, the more likely you are to develop cognitive impairment. And so if we get a very significant increase in the proportion of older people, very old people, we will have a very large burden of care for that subset of the population. That burden of care includes all kinds of personal care. We're not so much talking about hospitalizations or technologies as we are personal care. And the workforce for that personal care, I have not yet identified. I don't know where they're coming from.
Well, and the strain on families, middle-aged and young, old, taking care of the old.
There's no question about that, and there are all kinds of issues and much research done on the value of respite care, respite for care providers, et cetera, et cetera. I think it's a secondary phenomenon to this demographic transformation. If we're able to keep older people in the workforce, if we're able to keep the economy productive, we can probably afford to pay those people. The other good news, there are two pieces of good news on the Alzheimer's side, I think. And one of them is, of course, that the best predictor of Alzheimer's disease, unless you're in a family that has a very early onset and you have 2 doses of ApoE4, but aside from that, the best predictor is, of course, educational attainment. And what we're seeing now is that the last group of relatively uneducated elders are moving out of the population. And what we have behind it is almost an entire population with a high school education or better. And that's probably going to rapidly reduce the incidence of Alzheimer's disease, so that if you take the incidence at age 90 now, that's probably going to be higher than the incidence at age 90 10 years from now, because that cohort is going to be more educated. We don't know why education is so protective. There are 2 hypotheses. One is that more education early on in life gets more wiring, you know, and then when you get a disease that destroys your wiring, you've got more wiring left and you're more resilient. A second is that more educated people are more likely throughout their life to do cognitively complex things like read books, play a musical instrument, go to the theater, engage in conversation, do crossword puzzles, I don't know, whatever. And that this constant lifelong experience is beneficial. Both of those things sound plausible. So that's one piece of good news. The other piece of good news is that many drug companies are really betting very, very heavily on Alzheimer's disease. They are putting tremendous amount of money into research in Alzheimer's disease, enormous. Some drug companies, everything, all in on neuroscience, neurodegenerative diseases. And, you know, if we get lucky, we're going to come up with something that'll be effective. But I don't know what that is. I haven't seen it yet. But there have been a lot of swings and misses. But there's a tremendous amount of money going into this. Yeah. I mean, every Alzheimer's scientist that I know is getting job offers at big pharma companies every day, you know. Here, I'm going to quit Columbia and come and work for us, you know, and you don't have to write a grant ever again. And, you know, you can just do your research. Yeah.
This is more of a biological question. I wonder what your thoughts are on the maximum lifespan potential.
Maximum lifespan potential.
15 has been that way, it seems, for centuries. Do you see that ever changing?
There's a lot of discussion about this these days because there's a guy in the United Kingdom named Aubrey de Grey, who is a professor and the elite college, and he talks about people living very, very long lives. I spent a fair amount of time on this. I think that's baloney. I just don't see it. I mean, I think there are two issues here. One of the issues is related to what is the maximum human lifespan, so that you know, the argument that these longevity people make goes like this. They say, well, it's a little bit like you know, you see the lifespan of rats out in the wild, and you know, they live 2 years. And you think that's a normal rat lifespan, but then when you take them into a laboratory and put them in a cage and you keep them clean and you feed them every day and they live 4 years. So maybe you know, that was the maximum rat lifespan was 4 years, but living out there is a hostile environment, and you get infections and you get predators, and you know, that's why nobody ever lived more than 2 years. So maybe if we can get rid of the infectious diseases and we can get rid of the other things with humans, that they'll live much, much longer. That's one argument. And I would just say that the analysis that I've seen suggests that the competing risk is so great that that's not the case. That is, if you get rid of cancer, you know, heart disease is going to get you pretty quickly anyway, or if you don't die of heart disease, you're going to die of, you know, pneumonia or something. It's kind of one thing doesn't get you, the other will, and that it's very unlikely that there is a very significant potential advance to be had. The other thing, the piece of data against it, is the fact that no human has ever been documented to live past 120 years. And there have been a lot of humans, billions and billions of humans. So if the normal human lifespan really was 130 or 40, wouldn't you expect one person, at least just from a statistical point of view, to have lived to that? I mean, at least one, just one? The other side of the argument has to be with, okay, that's the human lifespan as we know it, but can't we change the aging process? And can't we fundamentally change the aging process to get an advancement? And my colleagues and I wrote a paper a month ago or so in Health Affairs that there was an article in Science and the Washington Post and NPR about, because we did an analysis of what the potential benefits would be of funding the Aging Institute with X dollars as opposed to funding the Cancer and Heart Disease and Arthritis Institute. You know, and because we think there is enough information available in animals to suggest that we can change senescence. But our analysis suggested that that would make people age in a healthier way, but it wouldn't necessarily increase the average life expectancy by very much, maybe 2 years. Whereas these longevity guys are talking 20, 30 years. So it's a long answer, but that's where I am. Yes?
I'd like to hear your opinion as regards to shortage of geriatrician in the U.S.
Sure,
from
sure.
health policy standpoint.
This gentleman, who is a Harvard-trained geriatrician, is actually my academic grandson. He was trained at Harvard, and the leader of the program and his mentor was one of my initial trainees when I was at Harvard. So he doesn't look like my grandson, but he is one. So the question that has to do with the workforce. And the workforce situation is dire, but I think I'm optimistic that it may improve for a specific reason. So there are very few geriatricians, and if you look at the number of geriatricians who are board certified in the United States, it's actually going down, despite the increase in the numbers available. And the reason is that if you are an internist or a family physician and you get board certification in geriatric medicine, your income goes down about $40,000 or $50,000 a year, because all your patients are now on Medicare, as opposed to a patient mix of an internist that includes some commercial insurance, which pays more than Medicare. That doesn't seem like a fitting reward for the additional training and additional debt you've taken on. And so there's an economic disincentive. And in addition, most of the fellowship programs are far from being filled, even though I would guess that most of the people applying for fellowship don't know that your income is going to go down if you become a geriatrician. They haven't figured that piece out. They're just not interested. Now, what we need is to forget about the idea of creating enough geriatricians to take care of all the old people out there. I mean, it's just, and particularly geropsychiatry. I mean, geropsychiatry, there's one geropsychiatrist in the United States for every 22,000 old people, whether they need them or not, you know. It's just ridiculous. But so what we really need to do is talk about competencies in geriatric medicine and getting medical schools like this one, and obviously you have a very good program here with Maryland, but and residency programs to include core competencies in diagnosing and managing the common disorders of late life, so that we turn internists into geriatricians and family practitioners into geriatricians, and the geriatricians amongst us can all be medical center presidents. Or no, I didn't really. What we can do is we can teach people geriatric medicine, we can develop new knowledge, we can lead programs, we can design systems of care, we can use our expertise in other ways. More leverage. Now, why do I think things are going to get better? I think things are going to get better because with ACOs, accountable care organizations, and if you think about the major ACOs to date, they've all been, the ones that have reported results, all been in the Medicare program, so they all have to do with old people. Well, these programs are now starting to get paid based on the quality as well as the cost of their work. They need to prevent readmissions, they need to prevent falls, they need to prevent all kinds of things that happen to older people very commonly, and in which they are expert. And so I believe that if I were running an ACO, I would be hiring whatever geriatricians I could find so that they could influence the care and inform the care and establish the protocols, etc. And, of course, I would pay them probably more, but at least as much as the other internists and family practitioners I was hiring. So they're all going to be salaried, and they're going to get out of the snag that being a geriatrician pays less. So I think what we're going to see is an improvement in the pay and an improvement in the market, if you will, for geriatricians. And with that, I think we're out of time, so we're going to stop. Thank you very, very much.